Hello, I'm Dr. Israel Barken, the Medical Director of the Prostate Cancer Research and Education Foundation. I'm going to discuss today a presentation of an abstract that happened this year, 2012, at the ASCO meeting, annual meeting. ASCO stands for American Society of Clinical Oncology. Dr. Maha Hussein presented a study from the SWOG, SWOG, which stands for the Southwest Oncology Group. The study included more than 3,000 patients. And the study came to answer a question, what is better, continuous or intermittent hormonal blockade? The group of patients they checked this on were patients that were still hormone sensitive, but they had metastatic disease. And here how the study was designed. They started with hormonal blockade, Zoladex and Casodex, for 7 months. If the PSA was below 4, then they randomized those patients to those that were taking the treatment continuously versus those that were taking it intermittently. And the intermittently was determined in such a way that they were put back on when their PSA went all the way up to 20, or when it went to baseline if the PSA was below 20 when they started joining the study. So here is what's so interesting. They found out that when they divided the patient to those that were minimal disease to more advanced disease, that means those that had more metastatic disease in the bone and were considered more advanced disease, and those that had some lesion in the lymph node and a few lesions, they were considered as minimal disease. So here is what they found out. When they looked at the patient that were minimally advanced disease, amazingly they found out that the group that were on continuous hormonal blockade, they had a longer survival than the group that were on intermittent. It was 5.8 years versus 5.1 years. And this is very interesting because you would want to believe that the more aggressive disease you have, the more likely you have to stay on continuous hormonal blockade. In the patients that were advanced disease, it didn't make a difference if they were on continuous or on intermittent. But those that had minimal advanced disease, it made a big difference. Intermittent hormonal blockade gave a shorter survival than continuous hormonal blockade. And this is very, very interesting because in clinical practice we tend to say this way. If the disease is aggressive, we really must put the patient on continuous hormonal blockade. And in this study, it showed it didn't make any difference if you are really advanced disease, if you went on intermittent or continuous. But if you have minimal advanced disease, then all of a sudden, logically you would say, or intuitively you would say, well, let's take intermittent. No. The intermittent treatment was inferior in this group with minimal advanced disease to those that took continuous hormonal blockade. So that raises many questions. Should we change our practice according to this? And I raise a very, very important question. And the question is this. At least here in California, we are used to giving complete hormonal blockade. First of all, giving most of the time 3 drugs, which include the Lupron or the Zoladex, the Casodex, and the Avodart or the Proscar. But even if we use 2 drugs, we tend to give it longer period of time, up to a year or even in some cases longer. And then when we do intermittent, we always try to bring the PSA after a year or so to very low level, way lower than 4.0, more like 0 point something. So the question, could you compare the patient in the study that they were treated with shorter period of time of intermittent, and they were treated with also with a different criteria when to restart them on intermittent? So can you really translate from one group to another? Probably not. But the problem is that we need to do more studies to compare this issue, and it comes to show you that in subgroup of patients that have minimally advanced disease, don't assume you could give them intermittent that because it's minimally advanced disease, and at least according to this paper, we should give them continuous hormonal blockade. My personal view is that we need better criteria when to give continuous hormonal blockade versus when to give intermittent. And when we give intermittent, we need better criteria when to restart it. And I think we have to add to the equation not only the PSA or the doubling time, we need to include imaging tests and markers to try to show us how aggressive really is the disease, and more important, after intermittent treatment for a while, what did it do to the cancer? Did it make it disappear or not? Do we need to give a longer period of intermittent because the cancer did not really respond? This is just my view, but I found this a very interesting abstract by Dr. Maha Hussein. It was recently at ASCO, again stating that continuous hormonal blockade is better than intermittent hormonal blockade in a group of patients that are hormone sensitive with metastatic disease but have minimal metastatic disease. In those patients, it's suggested that we should use continuous hormonal blockade instead of the intermittent. Thank you for listening. Hear from you next week. If you have any question about the subject, take care, stay informed, stay in touch, and have fun. Goodbye.